Good morning, everyone. My name is Isa. I'm one of the PGY residents at St. John Hospital. And this is my first poster presentation at the ACP under the title of Humoral Hypercalcemia of Malignancy, an unusual presentation of paraneoplastic syndrome of invasive metastatic papillary urothelial cell carcinoma. I was honored actually to work with my senior Cherry as well as the chief resident Benjamin Huber, who did actually help me a lot in this case. So let's go with the introduction of this case. As all of us know that hypercalcemia is one of the common feature of malignancy, and the mechanism behind that could be bone metastasis, could be production of PTH, or even vitamin D production like lymphoma. And in case of humoral hypercalcemia with production of the PTHrP, I think the lung cancer, ovarian, and breast cancers are the most famous cancers can do this. It is rarely described, rarely reported to have a bladder cancer and produce PTHrP. So we did find that this might be a case, interesting case for everyone to know about. So this is a 79 years old Caucasian male, and as I said, history of papillary urothelial cell carcinoma. And the main reason he came to the hospital was weakness, altered status, as well as lower extremity pain and hip pain. Physical exam, the patient was confused. Other than that, it was negative. And on the initial workup for the patient, his calcium was 18.3, for which we actually went so fast, and we gave him IV fluids. Also, we did the zoledronic acid, and we gave him the calcitonin. It was noted that there is improvement in his calcium, as well as the level of his the conscious level of the patient. So throughout the admission, the patient also got a CT scan of the abdomen and pelvis, and as you can see here, you can appreciate metastasis. Two types of metastasis, I can say. The osteolytic lesions, and you can see it here at the L3, and it's almost like half of the vertebra is included in the mets. And also here we have an osteoplastic lesion at the S1 vertebra, along with lymphadenopathy at the prevertebral area. And if you can see here, the patient also has like urinary bladder wall thickening and irregularity, of course, from the cancer. And the thing is, despite improvement in the calcium level, the phosphorus level continued to be low. So we did replace the phosphorus, but we were not able to achieve the normal range for the phosphorus. So we were asking a question: why the patient has low phosphorus level? And we did a PTH, and also we checked the vitamin D. Both of them were low, and this was suspicious a little bit. So we want to know an answer for that. So we went and tested for the PTHrP, and it came actually high. It was 8.6. And for that, we did confirm that there is a paraneoplastic humoral hypercalcemia of malignancy going on with this patient, for which we did refer him to hem-oncology for follow-up, further evaluation, and also for treatment. And this brings us to the discussion section, and I can say that the humoral hypercalcemia of malignancy is, by definition, the ectopic production of PTHrP, which stimulates the osteoclasts to release bone calcium. And this hypercalcemia will cause a variety of symptoms, include confusion, as what happened in our patient, and polyuria, and maybe common death. And there are many mechanisms behind that, and includes the metastasis to the bone, PTH production, vitamin D production. And the initial management should be definitely the volume expansion with normal saline solution, along with maybe bisphosphonates and calcitonin. And the case here also, the home message that I want everyone to take home from this case is try to make your differential diagnosis broad and think about not also the metastasis, but think if there is any lab abnormalities that doesn't make sense for you, please go and test. And in this case, the patient has metastasis as well as PTH-RP elevation. And yeah, that's it for my presentation. And thank you everyone for listening.